Well, good afternoon, everybody. Welcome to Open Classroom. Happy New Year. This is our first program of 2022, and we are super excited that you're with us. I'm Janet Gillow, the Director of Professional Development for the Brown School here at Washington University in St. Louis. Want to welcome our audience joining on Zoom. Y'all probably know this about Zoom webinars by now, but like to make sure everybody knows we can't see or hear you. So keep on having your lunch or doing what you're doing. Chat features enabled, and we do want questions and comments from the audience. So we're getting some greetings coming in and already some questions, which is fantastic. That's what we want you to do, to be as engaged as possible. I want to extend a special welcome to anybody joining on YouTube. We're live streaming right now, and this recording will be available later on. Delighted to have you with us, and want to make you aware that we're not able to moderate Q&A through YouTube. So I'm joined by Cynthia Williams, who's the Assistant Dean for Community Partnerships here at the Brown School. And as this is the first in a new series we're doing with our admissions office, we're also joined by Sarah Birch. Sarah, would you like to share a few thoughts with us from admissions?
Yeah, thanks, Janet, and hello, everyone. Thank you all for joining us today. I want to give a special welcome to prospective students of the Brown School. We're very glad that you're here. As Janet shared, my name is Sarah Birch, a she, her pronouns, and I'm an Associate Director of Admissions and Recruitment for the Brown School here at Washington University in St. Louis. And I am thrilled to welcome everyone to our first open classroom of a new series that we launched this year called Curriculum Showcase. I'd like to thank Janet and the Brown School Professional Development team for partnering with admissions to bring this really great series to our prospective students as well as to the community. And so we hope that you will gain from this open classroom is a little more knowledge about the topic being discussed, and for prospective students, a little bit of a sense of what you can expect in the classroom with the renowned faculty members who are being featured in the series. Today's session, as you are likely aware, will specifically offer a sample of the type of issues addressed by our health policy analysis curriculum in the Master of Public Health program. Also want to extend an invitation to everyone to join us again this Thursday at 12:30 p.m. Central Time to hear Chair of the Epidemiology and Biostatistics Specialization, Dr. Deborah Salvo, who will be talking about spatial epidemiology. And be sure to register for many other open classroom programs that are coming up in the next few weeks, featuring faculty like Benjamin Youngdahl, Professor of Social Development, Sean Joe, our co-interim dean, Dr. Rodrigo Reyes, and Associate Professor Trish Cole. Again, thank you all for being here. Thank you for having me. And Janet, I will pass it back to you to introduce today's speaker.
Great. Thank you so much, Sarah, and welcome everybody. Cynthia and I are both Brown School alums, so we're delighted to welcome all of you to this family in this program. It's my great pleasure to introduce our speaker today. Tim Mcbride is the Bernard Becker Professor at the Brown School, and as Sarah mentioned, he's co-chair of our health policy specialization within the MPH degree. Tim is an influential health policy analyst and a leading health economist shaping the national agenda in health insurance, health reform, and rural healthcare access. He's an expert on Medicare and Medicaid. And in addition to being active and testifying before the US Congress and the Missouri General Assembly on issues regarding healthcare access, he's one of our frequent guests and favorite contributors for Open Classroom. He tackles complicated issues in a way that makes them relatable, and his passion for getting healthcare to the underserved is inspiring. So it's my great pleasure to welcome my friend, Tim Mcbride. Please take us away.
Oh, that's fabulous. Very warm welcome. Thank you, Janet. I appreciate that. And this is not my first time presenting. So, I appreciate again, your warm welcome. And I've been looking at who's in the audience, and it's a fascinating mix of community folks, healthcare providers, prospective students, people from all over the world, literally, which is pretty cool. So happy to have that group. And I'm going to share my screen here and get started. And you can see that, right?
There he is.
So what I'm going to talk about today is the Medicaid Expansion, Missouri, which is now going live, and the enrollment has started. Well, I'll talk about that in a few minutes, but I call this slide the show the long winding road. And if you're that's interesting. My picture disappeared, but if you're a Beatles fan, pretty loud, I can turn that down. So if you're a Beatles fan like me, that's why I picked that topic title, because one of the things that I'm going to point out to you is how long it's taken to get Medicaid expanded in Missouri. When it expanded with passage of the voter initiative in 2021, I thought back to when I first started working on Medicaid expansion, and it was 16 years before that, in 2005. So it's literally been a long and winding road. So that's kind of the purpose for that title. So there's the picture again. So I'm gonna talk through, and I think I was told that again, to sort of mimic one of the topics we would be talking about in our health policy classes, and this is certainly one of them. We try to bring to our students live important topics of things that are going on in the community and in a state, the region, and the country, and the world. And certainly Medicaid expansion is a real live policy topic that we would talk a lot about. So slides like this would be ones that I would present in my health policy class. As this slide notes, the research that's backing up a lot of this data and presentation has been supported by the Missouri Foundation for Health, one of our favorite partners. So I want to acknowledge that. So just an overview, what happened in with Medicaid expansion in Missouri. Missouri was the 39th state. I like to say 39, some people say 38, I include DC, to expand Medicaid, and in August 4th of 2021. It was somewhat unusual, although Missouri was the sixth state to pass the Medicaid expansion through a voter initiative. As you can see, there were 6 states that did that. What's somewhat unusual about Missouri, and this will come up later, is that we passed this through putting it in the Constitution rather than just simply a legislative mandate, which ended up being pretty fortuitous, as you'll hear. And the voter initiative passed 53 to 47, as you can tell, and won by about 82,000 votes. So just a real high overview of some things that Medicaid expansion does. It expands eligibility to Medicaid to all adults below 138% of poverty. But one of the main things that it does, other than mandating that coverage, it changes how that's paid for this group, which we'll be calling the adult expansion group as I go along. Currently, in the way Medicaid law is written, it's a shared federal state program. The federal government pays as little as 50%, but as much as a pretty high amount in the lowest income state in the country. In Missouri, the federal government pays 65% of Medicaid recipients' costs. Under expansion, it would pay 90%. So that's really important because it means that the state's cost is not 35%, but 10% of the healthcare costs. And that's a pretty big incentive, or it should be, even though Missouri resisted it for a long time. And the other thing that I really think is extremely important to point out to people is, prior to this, Medicaid only covered certain eligibility populations, and the aged, the blind, the disabled, pregnant women, and children under what's well known as the CHIP program. That's how children are covered. And you can see the eligibility levels below here, up to 300%, 3 times the poverty line for kids, which is quite generous. We were actually one of the first states to create that program. And pregnant women up to 200% of poverty. But our eligibility level for the parents of those kids is one of the lowest in the country. It's only 2 or 3 states that are lower at 21% of poverty, which means that you can make 25% of poverty and not be eligible for Medicaid or before the expansion. And poverty level, just so you know, is about 13,000 for an individual, as it says here, 12,880. I need to update that to 2022 now that we're in 2022, about 22,000 for a family of 3. So it's not a heck of a lot of money, and 20% of that would be, only about $4,000 over a whole year. And Medicaid expansion makes you could earn up to those dollar amounts and be eligible up to, in fact, 138% of poverty. And also note the important thing is that if you're a single person, childless adult, you were not eligible at all for Medicaid prior to the expansion. So the important things again that this does is it expands eligibility up to almost 18,000 for individual, 30,000 for a family of 3, and it expands it to those people who don't have children. So what I said it was 2021, it was actually 2020 when the voter initiative passed, 53 to 47, and it did 2 main things. It required the state to file a state plan amendment in March 2021, which they did, which basically said this is how we plan to do it, and it required the state to expand coverage in July 1st, 2021, and which this we'll hear that the state did not do until there was a lawsuit filed, because the legislature refused to fund expansion, and the governor then, with no funding behind it, pulled the plug and said, we're not going to do it, withdrew the state plan amendment, and then a lawsuit was filed. But after going through a few months of that, it went to the Missouri Supreme Court, and they ruled unanimously, which was, you can't get more definitive than that. It basically said the voters have spoken, you have to expand Medicaid. And so that was at the end of July, but the state begged for a couple extra months to get it started. So technically, you'll see that we started enrolling people in October. One thing I want to sort of point out real quickly is that much attention has been paid to the margin, which is fairly narrow, and which parts of the state voted in favor of expansion. That's the sort of turquoise parts of these maps, and this is a map that appeared in the St. Louis Post-Dispatch. And as you can tell, it's basically the 4 clusters of urban areas that voted for Medicaid expansion, and the whole rest of the state voted no. So many people sort of said, oh, okay, well, it's urban people are in favor of this and rural people are not. And here's the counties that voted no, and there's a lot of numbers here, but the main sort of point is that in these 7 or so counties, 8 of them, that voted for expansion, almost all of them are urban counties, but a couple of surprises in there that really kind of surprised people. The counties around Springfield, St. Charles County, which is fairly conservative. And so those counties voted yes. But I also want to point out that 204,000 people in the rest of the state voted yes, even if most of their compatriots voted no. So if you break this out a little bit differently, if you look at the breakdown from rural urban areas, it was roughly a yes vote 2 to 1 in urban areas and a no vote 2 to 1 in rural areas. But nevertheless, 142,000 rural people voted yes. So there's a lot of ways to cut this, and political scientists can have and stare a lot at this because it's pretty interesting. So what impact will expansion have, and where are we now? One thing that was, and there's a lot of words on this slide, but I'm going to pull out the main things. As the state was fighting over expansion. The governor first came out and said, we have the money to expand it, and we can do it without cutting any other spending for education, roads, and so on. The estimate was this Medicaid expansion would cost $1.9 billion, cover 274,000 people. The state share would be somewhere around $130 million, with the federal government paying all the rest. But I want to point out that in the American Rescue Plan that was passed in the Congress, the state got over $1 billion. Actually, it ended up being a little bit less than $1 billion. The estimate going in would be more than $1 billion. Just for as soon as they turned on the spigot and said we're enrolling people in Medicaid, there was an extra incentive to enroll people. So the state certainly has the money for the next foreseeable future. If our share, it's only a little over 100 billion only, but we have $1 billion in the bank to help pay for this, billion with a B. So that's an important budget point. Nevertheless, the legislature said we cannot afford it and we're not going to fund it. And they said we're not even going to authorize that 100 million, even though it would bring in almost $2 billion into the state. Advocates had expected a fight to happen. So they filed a lawsuit as soon as the governor said he wasn't going to start expansion. The lower court said the amendment was unconstitutional, which was a bit of a surprise to some people. And then both parties involved in this agreed to skip the appeals court and go right to the Supreme Court. And on July 22nd, expansion was unanimously approved. So I've done talks on this before, and you may have heard me. The current status as we speak is we started enrolling people in October 1st. And even if a person files on October 1st, the lawsuit said that they could get their bills passed, their medical bills passed backwards to July. And as you can tell, by the end of October, we have somewhere over 53,000 people enrolled in what's called the Adult Expansion Group, Adult Expansion enrollees. So I'm going to talk about that number. I think it's fair to say that it's lower than what was expected at this point, because even the governor's estimates were that about, again, 274,000 people would enroll over the course of a year. And they expected about 100, more than half that population to enroll in the first couple of months. So we're clearly not at that, but notice that we have 69,000 pending applications. And so nevertheless, even though the expansion enrollment is relatively low right now, if all the 69,000 applications go through, they all won't, but let's say 68,000 do it. So it will be at about 120,000, which is, probably most people would say a good start. There's some questions about that in the Q&A and then in the chat, so I'll get to that in a minute. But one of the things I wanted to show you was the backdrop against which this is happening is the enrollment in Missouri Medicaid looks like this chart. The pandemic, as you know, started late 2019, early 2020. And as of that moment, a national health emergency was declared. And what that meant was that people who were then on the Medicaid program, who were later went on the Medicaid program, couldn't be withdrawn. That was the judgment of Health and Human Services. And so you can see the effects of that as our Medicaid enrollment went from 850,000 to it's currently at about 1.2 million people, the highest it's ever been in the state. And, many people believe that a lot of those people would be removed if the national health emergency ends. For example, some of them are kids who turn 19 They're no longer eligible for the children's health insurance program, but we've had other times when enrollment goes up and it goes down. It's like a roller coaster. But this is the whole Medicaid enrollment, not just the expansion. So I mentioned that there are about 53,000 people statewide that are enrolled. These numbers don't match that exactly because they were from the previous month. We track, as I'll tell you, the enrollment by county. And at the end of November, there were 21,000 people enrolled. So you can see it pretty much doubled in a month. But I wanted to sort of show you how that relates to our projected numbers that we thought would be enrolled. And again, show it for our local area. If there's people that are from the local area that might find this interesting as a way to think through it. Our center did estimates of how many people would be enrolled by county. And now we can look at how many people are enrolling by county. And at the end of November, as you can see, the 21,000 translated to about a little under 8% of the projected enrollment. And in St. Louis County, that enrollment rate was the highest in the state at 13%, 2,300 people. In the city, 1,300 people, but we projected 28,000 would enroll. So there's obviously some way to go here. And I see there's already some questions in the Q&A, which I'll probably address right now. Why has enrollment lagged in Missouri? And this fairly busy slide again, but there was a very good article, which you'll see linked at below in the Kaiser Health News by Bram Sable-Smith, who talked about the comparison between Oklahoma and Missouri. Both Oklahoma and Missouri passed expansions to go into effect at pretty much the same time. Oklahoma's June of 2021, ours was supposed to go into effect in July. And as you can see there, Oklahoma's already enrolled 237,000 people, which is remarkable for a state that's actually smaller than us, although it does have a higher poverty rate. They had projected that about 200,000 people would enroll, and they're already over that number. We, in contrast, are at about 53,000, as I told you. So that sort of makes people go, well, what's going on? Why are we only at about 20% of our projection rather than, say, 50 or 100%? We had, again, projected maybe we'd be at about half the enrollment by now. And I list several factors here. One is the legal challenge itself, which basically cut off 3 months where nothing was happening and delayed the start of the enrollment. So we started in October, not July. So that's clearly one issue. But I think that legal challenge also has sort of led to some confusion and awareness of what's going on, because as I go around and talk about Medicaid, people know that I work on this, and there are people that are, people are healthcare providers or others who say, when's expansion supposed to start? And I go, it's already started. There's just not a lot of awareness of it out there because there's not a lot of press about it. It became very confusing because it was on again, off again. So I think that's part of the problem. We were talking earlier among my colleagues about this, that there really hasn't been much press about this. But also say that the state has done little outreach to the eligible populations. They, pushed back a little bit on that. They said, oh, we put it up on our website. We put out a little bit on social media, but they have not been extremely proactive. They will also tell you they don't have enough staff, which I think is true. And they're obviously right now, they're kind of beleaguered because of COVID and a lot of people being sick and so on. But it's been hard for the state to do it, they say. Although if you look at what Oklahoma did, they basically took on the outreach challenge themselves. In Missouri, it's really been non-governmental organizations that have done it. As I pointed out to you, we have 69,000 applications backlogged, which is a lot. A lot of that might be the people who applied through the marketplaces in the last few weeks, and they eventually will get through the process, but it's taking over 2 months to enroll people. It used to be 5 days, but right now it's taken 65 days to process applications. Or the last number I saw in the management report, which is a long time and speaks to the shortage of staff that the state has to do this. And again, once we get through those applications, we may have over 100,000 people. Another thing the state really hasn't done very much of is there are some populations that they're currently covering that they could move over to the expansion group. For example, pregnant women currently or were already eligible for Medicaid when they were pregnant for a few months before they were pregnant and a few months after they're pregnant. If you're below 138% of poverty line and you're a new mother, you could just go on the expansion population. And the state has several groups like that, which they could convert sort of immediately into the adult expansion group, but that process has been quite slow. It's what everybody tells me. I think they eventually will get around to doing that. And there's a financial incentive to do it because they'll get 25% more federal dollars, but it's moving slowly. So, Janet and I were talking earlier about what in the absence of a lot of awareness or press on this, what could be done is I list three things here. Raise awareness, let people know Medicaid expansion has happened. It's already happening. It's already people enrolling, as you just saw, which might surprise people. There are maybe 5 times the number of people that are already enrolled that are eligible. So maybe outreach to those groups. And here's a couple of examples of flyers that are available to do that, which could be put on social media, on Facebook, Instagram, whatever. And I've seen them used. The one on the left was produced by Missouri Foundation for Health. And if you go to the link below, and I think, Janet, thank you for putting those links into the chat. You can go link on those yourself. And Missouri Foundation for Health has a big toolkit, which you can use to download videos and GIFs, posters, that kind of thing. DSS, the state, also has a website where people enroll and information about how Medicaid expansion works. So there's a link to that. And there's a whole coalition called the Cover Missouri Coalition, which has additional materials. So that would be what I would suggest, is that outreach, awareness, and assistance needs to happen. I'll emphasize the assistance because I think there are a couple of questions in the chat, which we can get back to later more fully, but I noticed that at least one person said, where can people go to get assistance to enroll, especially if they live in maybe a rural area or it's not clear where to go to get assistance. There are assisters that are available across the state, most of them paid for by the Missouri Foundation for Health, but other health providers are doing this as well. But it may be a little hard to find them. But I think if you go to the MFH website, you'll find some of those assisters. And if any of you know what it's like to enroll in Medicaid, it's not the easiest program in the world to enroll in, although the state's, to its credit, is trying to make it easier. They're trying to simplify the enrollment process, but it's still not easy. And some of these assisters are available to help people. So that's sort of kind of where we're at right now in terms of and what needs to happen, I think, because clearly we are not hitting the enrollment targets as we speak. But I'm ever an optimistic person, and Medicaid should be available for those who need it. And maybe it still will happen in our state, albeit more slowly than projected. One thing I wanted to point out to you is we have created what's called Medicaid or MoHealthNet enrollment tracker in our center. The link to that is in the slide, and maybe Janet will throw that in there too. And so we're trying to track in as real time as we can just some of the basic data about Medicaid. So people may want to sort of bookmark that and watch it as we go along. And right now it's all based on administrative state data. We may add some of our own data later. And the reason we did this was because sometimes navigating the state and figuring out what's in their reports is pretty difficult, and knowing exactly where to go find what you need. So we try to make it more user-friendly and helpful with, as I'll show you in a second, graphs and charts which are interactive through Tableau. So here's one example that shows that line that I showed you earlier, the total number of enrollees in Medicaid, but it's broken down by what the types of people that enrolled in this little purple sliver over on the right, which you can barely see, is the adult expansion group, which through November again was only about 20,000. But so what you can go in there and look at this interactively and look at the number of people that are enrolled. We also have what I think is, I've been told is pretty helpful, the breakdown of the enrollment by state, I'm sorry, by county. And in this chart, which mostly looks pretty pale at this point, but is a number of people in each county. And you can see that the highest numbers are probably not surprisingly in St. Louis County and around in Jackson County around Kansas City. But this is maybe helpful if you're working to try to enroll people. We also, there's a lot on this visual, but this shows the number of applications as they're received to Medicaid. And one thing you'll notice here, I kind of call this a leading indicator about how Medicaid expansion is working. If they're not actually on the rolls, but if they've applied, they're in process. One of the things you can see is after August, not surprisingly, once the lawsuit was decided, the number of applications started to really climb to 13,000, 18,000, 38,000. We haven't seen the December numbers yet, but you can see that's higher than any previous month and even a year ago, which there's always an uptick in enrollment around this time because people go back to school, the marketplaces open up for Medicaid. And this allows you to look at where those applications are by county. If you're somebody who's trying to help people and how actually people apply, which that's a little in the weeds. Happy to talk about that later if you want. But and finally, there's a whole slide about which managed care plan they are enrolled in. There's 3 of them in our state. The Healthy Blue, as it's called, run by Blue Cross Home State, which is run by Centene, and United Healthcare has a plan. And for us wonky type people, we want to know how that is distributed. People are automatically enrolled in managed care plans when they go on to Medicaid. So hopefully that tracker is helpful to people, and I would encourage you to keep following it as we go along. I'm going to try to be mindful of time so we can get to questions in a few minutes, but so I'm going to probably just skip over some of these slides, but what impact will expansion have? We thought a lot about that in the early implementation grant that we had through our center, and we put out, as you can see here, 5 or 6 briefs. Actually, I think it was more like 8 that covered a lot of these topics, which I won't have time to dive into in real depth, but you can download the briefs yourself on that link. So we looked at what we project around enrollment, including by type of people, where in the state they would enroll, and so on. And we looked at the effect of COVID on the Medicaid. We looked at the demographic characteristics of the enrollees, and why that's important is because if we enroll a lot of healthy people, it's going to be cheaper than if we enroll a lot of sick people or people with disabilities. And there was some concern that because the current Medicaid population, it's designed to enroll people who can't get health insurance otherwise. And as I pointed out, current Medicaid program includes the aged and the blind and disabled. which, appropriately, I would say, because it's often very hard for those folks to get health insurance. So their costs can be pretty high, well over $10,000 a year. But I don't expect that will be true of the new Medicaid enrollees, because a lot of them are working and they're more healthy, as you'll see in some of our briefs. We talked about the geographic distribution of enrollees and their health characteristics, as I just mentioned, where they get their health care now, or where not, is probably the bigger question. And a big question that a lot of researchers have been thought about is when we add 274,000 people, as we made, to the covered roles, does our state have the capacity to care for those people? And so we dealt with that. Also, in my health policy class, what I would walk people through is not only how you do this research, but how you present it. I think it's important in a policy world that we often present our work in policy briefs, as we call them, and we talk about how to do that. And the examples that I'm showing to you, which you can download and tend to look like this, it's important that these briefs have a lot of graphics, be visual, be accessible, not a lot of jargon. You have to every time you do Medicaid, but anyways, we would talk about that policy analysis process. And so in the I'm going to try to end by about 1:15, I think, so we can address some questions, but I'll just going to run through real quick some of our findings that we did in that preliminary research. Again, we had expected to enroll 274,000 people. Of that group, it might surprise you that not all of them were currently uninsured. Some of them would come over from having marketplace coverage, that's the 29% here, or some of them may drop their employer plan if they're part-time and it's pretty expensive. They would be allowed to drop their employer plan and come in. We didn't think that number would be very big, but nevertheless, you can see they're going to come from about 3 different buckets, it is estimated. Here's some of the sort of key findings we found in all of our briefs. We found, and this has ended up not being true, but we projected that about half the adult expansion group may enroll in the first month or two. We base that on previous states' experience, because in all the previous 5, in the most recent 5 states that expanded Medicaid, that's what happened. About half the people who were projected to enroll came in the first month or two. That's not happening in Missouri for reasons that I talked about. We expected that obviously the greatest numbers of people would live in urban areas, but a higher proportion would live in rural areas. Let me show you that real quick, because I think that's important. While 32% of the population in Missouri lives in rural areas, we projected that 41% of the enrollees would come from rural areas, and that surprises people some, but it's because rural people across the whole country, I've been doing rural research for most of my 30 years, have lower incomes and higher poverty rates. So paradoxically, in some ways, this Medicaid expansion will help rural people more than urban. Going back to that previous slide, we found that the adult expansion group we expect will be younger and healthier than the current population. They're going to have better health status and mental health status. However, there is significant needs in terms of chronic health conditions. And that's documented in our briefs. I won't have time to cover all that today, but and there are certainly evidence of access issues in this population. So I think I'm going to want to end here in a few minutes. I'm going to skip some of these slides and go to the future and the opportunities, the challenges, and the uncertainties that we face. And here's a list about 5 of these, and then we'll open up for questions. One is enrollment and outreach. We're already seeing those challenges. What challenges are we going to face? And we're seeing some of those challenges now. And what is that going to look like in the future? Is there going to be equity in the process during outreach? So in other words, no matter what your, as long as if you look at two people that are otherwise the same, that live in different areas or different race or ethnicity, do they all have access to the process? We want to ensure that's the case. Do we have enough providers to take care of the recipients? There's been some worry that Medicaid recipients will come in with so-called pent-up demand. They may have not had health insurance coverage for a long time or ever, and then they'll come in and say, look, I have diabetes or I have heart disease, and the cost may be higher right away. So that might be something to watch. I mentioned the rural health issues. One issue in particular is that rural health systems are a challenge across the whole country. We've seen more rural hospital closures in the last 5 years or so than we saw in the previous 15 years. And this map here with the little dots on it is where those hospitals have closed. And you can see, if you kind of know where the states have not expanded, it's mostly in the South and in the Midwest, upper Midwest. And many, if not most of the rural hospital closures have been in those states. So one thought is that expansion may end up helping rural hospitals in Missouri. We've had about 8 to 10 rural hospital closures in this period, and the additional funding maybe will help them. And there's a lot of words on this, but the main question is how well will this work for managed care? Most of the people frankly, all the people that are going to go into the adult expansion group will go into a managed care program. And the question is, will they have the same access to coverage or practitioners across the state? And there's a brief done by the St. Louis University folks that's really quite interesting to look at in this regard. And then the budget challenges, will this be a burden on the state, or will the state be able to pay for this? Looks to me like they will, because they have that $1 billion in the bank. But that's obviously a question that's worried a lot of folks. And so these are some research questions that, the kind of things we would tackle in my health policy course and other courses in the university. Frankly, I point this out to people. You can maybe tell that I'm all over this topic and have been for 16 years, but this is what we might call a natural experiment. You don't see this big of a change in policy very often anywhere. When you all of a sudden turn the spigot on and make 274,000 people enrolled, there's a lot of researchable questions around the barriers to enrollment, around who's enrolling and does their access to healthcare improve, and do we have the providers we need? How is managed care going to work, and so on? The questions I just addressed. So I frankly push my colleagues to say, you should be studying this, you should be studying it, and we train our students to do that. So I ran through that fairly quickly, and I may stop share because I want to see people. And so I think we have about 15 minutes left. I want to leave a lot of time for questions. So how do you want to handle those questions, Sarah or Janet or Cynthia?
Hey, Tim, thank you so much for that information-dense presentation. It is extraordinary, all the information and expertise that you have on this topic. And thank you for fielding most of the questions in the Q&As, but there's one question from Emily. How much did the amount of cost increase from before expansion to after?
That's a really good question. And I don't think we really know the answer to that. I will tell you, it's a question of if you're talking about aggregate costs or cost per individual recipient. I think that's the open question. As I pointed out to you, the governor himself or his staff in the legislature expected those 274,000 people to cost $1.9 billion. And that's the overall costs, but this cost of the state was, they projected a little over 100 million. We have a different projection. We expected it would be closer to zero for reasons, I could talk about, but that's just a difference of opinion and how you apply assumptions and so on. But as you can tell, we've only enrolled 53,000 people so far. So the costs to the state at this point are probably significantly less than that 1.9. The overall costs are less than that 1.9 billion. And and as I mentioned to you, they have $1 billion in the bank. So whatever state costs the state have can be covered at least for several years. I think we won't know the answer to Emily's question for a while until we know exactly some more about the people who are enrolling. And that data is going to come in the next probably couple months. There's some researchers at Missouri, University of Missouri, who have access to that data. And we'll know, for example, are the people enrolling like 22 years old and part-time workers, quite healthy, or are they more like 50 years old with diabetes and heart disease and a lot of pent-up health issues, and so maybe their health costs are pretty high. We don't really know that answer yet, but we will know probably in the next few months.
Thanks so much, Tim. So much information covered and more questions than I think we could address in a couple hours. It's not going to surprise you that the audience really did clue in on, wow, the enrollment in Missouri is not what was projected. And, people wondering things that my hunch is that you're not privy to. And certainly if it gets to questions of like motivation or resource allocation, you wouldn't necessarily know, but people wondering, okay, so what has been the plan to get the word out, or how might the plan be improved? I recognize you may not have those details, but I'm also curious, like if we're looking at Oklahoma as a contrasting case of like, wow, they funded it, they did it, they enrolled. Do we know what they did that we have yet to be able to do here in Missouri?
Yeah, I would, and that's going to be, this is a fascinating, if you think about it, like a health policy class study. This is like, a great research topic, a great thing to dive into, because we have two states that are right next to each other in the middle of the country, relatively, Oklahoma has higher poverty rates than we do, a lot of the same kind of diversity. And although Oklahoma has much higher Native American population than we do. But in any case, the contrast is really pretty dramatic. And if you read that Bram Sable-Smith article that I referred to, we were going to write an article about what was going on because we dove into it and we said, wow, what's going on? And we talked to some people in Oklahoma and it became pretty clear, and he did a great job of laying it out. So I addressed it in what my slide was talking about. It was, as you just said, Janet, Oklahoma embraced this and took it on, and they said, obviously Oklahoma has a conservative legislature, they resisted it, but then they just said, okay, we're going to do this, let's do it right. And for example, they told us there's a person named Mr. Medicaid. I haven't figured out who Mr. Medicaid is, but he goes and tries to find people all over the state who are not enrolled. I mean, literally, I'll tell you, we were told that, you saw that we did projections by county. We have 115 counties in the state. And so they would look at a county and they would say, oh, we projected that, say 500 people were supposed to have enrolled here, but we only are seeing like 100 people are enrolled. And then they would send people up there and say, where are the remaining 400 people? And then just basically try to outreach to them and say, you might be eligible for Medicaid, you should sign up. We're not doing that yet in our state, although I will tell you that that process has started. And Missouri Foundation for Health has funded a lot of that. Other NGOs and probably some of the people listening are doing some of that. So, And I think the story that tells you is that, we're doing this through the nonprofit sector, through health providers, and not so much through the state for whatever reason. I think a lot of it has to do that we just don't have the staff in the state to do it, or there may be other reasons I can't speak to without evidence. But so I think the outreach to folks is really important, and the awareness, I think, really is a problem. Because, again, since we had the most contentious fight over Medicaid expansion that I know of in the whole country, people may not realize this, but we're the only state in the country that voted twice by statewide referendum against Obamacare, the only state. So literally they voted twice to say we don't want pieces of Obamacare, once the mandate and once the marketplaces. So that's the environment we're in. And that means that there's going to be historic resistance in the state, and that's a challenge. You would think you'd encounter that in other so-called red states like Oklahoma, but it's clearly playing out differently. So I think we need to do the kind of things I talked about: awareness, outreach, and assistance. Does that answer your question? I'm not sure it does, but there are other questions. Go ahead.
Yeah, Jonathan asked, will expansion of Medicaid have rural hospitals, or is it too late, Tim?
Oh, that's a great question. It's a sad question in a way, because as I showed you just very briefly, rural hospitals are really challenged, and they have been for the last 5 or so years. Just at a high level, what I'll tell you the problem is the size of the hospital, which means it's harder to cover fixed costs from an economist's point of view. And then we know from a lot of research that rural people are sicker. They're more likely to not have jobs. And there's just a lot of challenges they face. And so, it's a lot easier to pick on my own employer. It's a lot easier for BJC to cover losses if they come in a short run, such as what you might face in COVID. But if you got a small rural hospital, it's got 50 beds, and you get blasted by this, that, or the other thing, you're going to go under. And just like Walmart can survive on a 1 or 2% margin, that's what the kind of margins we're talking about with hospitals. They generally run, somewhere between 0 to 10% margins, or often less. But in rural areas, they've been negative for a long time. And they have the boards, and they can't just run negative balances forever. And the thought was, with the Medicaid expansion, that might turn that -1 margin into a +1, and that might be enough to keep them going. But if there are margins too negative, and if they've been struggling for too long, unfortunately, it might be the case that it might be too late. And that's what we're worried about. We're going to watch that very closely, I think, Cynthia, to answer your question, or whoever answered it. Because I think, this is a national challenge right now, not just a Missouri challenge.
Thanks so much for that. A question from Heidi that gets to some specifics on coverage. She's saying that she understands adult Medicaid expansion requires coverage of PT and OT, which has traditionally not been guaranteed or covered for other Medicaid patients. This can be a huge deal for people with chronic or progressive conditions that are trying to, stay as active and healthy as possible. Can you confirm that? And are there other coverage differences for this adult expansion group?
Yeah, I believe that is correct. And that would be something like right now that would be helpful to me, because I just broke my foot about 8 weeks ago, and I'm out of my boot, and I'm using PT right now. And I can tell you, I love those PTs, because, man, it hurts, but it really is getting me back to walking again. So it's really important. There's a long list of services that are covered and not covered. The federal government requires certain things to be covered, the ones you would probably expect: inpatient hospitalization, physicians, and so on. but there are certain things that are so-called optional programs. For example, dental, believe it or not, is an optional program. And a few years ago, the state cut dental out, but then they put it back in. And, you know, you probably know that if you let your teeth go for years, if not decades, or, you know, you could actually end up in the emergency room. And some people have been known to die from a dental problem. So it's really going to be a huge, important improvement that people get dental coverage. The other one that we looked at a lot was mental health coverage. If you go look at one of our briefs, Missouri, you know, this expansion will expand access to mental health. And even people with insurance have access problems to mental health, especially at low incomes, but all of us do. And so this would be really important that these expansions happen. And there's, you know, and I would show this to my students at the time, there are over 400 studies now that have been done about Medicaid expansion around the country. Again, this is a great natural experiment. And if you go to the Kaiser Family Foundation, you just type it, what I usually do is put in KFF and hit enter, and you'll get to their website. They have a survey up there that covers all 400 articles and talks about all the different things that are covered under expansion and what the effects have been. And it's really been, as you would expect, you know, not 100% certain that about everything, but it's been, there's good evidence for almost everything that we expected to happen.
Great. Again, we are hitting time. There are so many questions, and I'm trying to keep the discussion as focused as possible on the Medicaid expansion implementation and where we are right now. Tim, we're going to have you come back to talk about some of these broader themes of healthcare finance and what we can learn from other states, because truly we could keep going. But we're down to time for last question. And what I would love to know, to the extent that we know it, is if the goal of Medicaid expansion was at least in part to increase healthcare access and reduce uninsured population, understanding not only uninsured, do we know anything about how rates of uninsurance in Missouri have changed since we have this option?
We don't know that yet, and that's going to be one of the biggest questions we're going to be looking at, clearly. I will tell you that Missouri, and this might surprise people a bit, we actually have an uninsured rate even before expansion that is not the highest in the country by far, because we had a pretty robust economy during COVID, and even before expansion, our uninsurance rate was a little over 10%, which is nowhere near as high as it was in California, Florida, Texas. Those are the ones that have the highest uninsured rates. In part, that's because of their demographic composition. Turns, you know, if you look at the data, the highest uninsured rates are almost always Latinos, and second, African Americans. And a lot of states, those other states that I listed, have higher proportions of those populations. So in general, we started with a lower uninsured rate. It's dropped since the Affordable Care Act because of the marketplaces in particular, and our improving economy even before COVID. And we actually weathered COVID pretty well. And, you know, we've talked about that before, Janet, in these presentations. So, but I think to answer your question, the expectation was that this might lower the uninsured rate to, as you know, close to 5% or so. Or they're not all going to go away, because this only covers people up to 138% of poverty. And some people are just not going to sign up. You don't like government or whatever it is. And there are some people that are not eligible, non-citizens are not eligible. But you know, the expectation is we may be able to cut our uninsurance rate in half, but we'll just have to see in the end. And we'll probably know that probably 9 months or so from now.
Sounds good. Well, we would love to have you come back to share that. And again, there's clearly in this audience just a strong appetite to learn more about the things that you study and know so well and explain to us so clearly. So Tim, we're at time. Is there a final thought that you want to leave everybody with, a call to action, or
yeah, as you know, as I started off, I pointed out that I've been working on this for 16 years, and you have that luxury as a professor, but most professors are obsessed about a topic, and if you work on it and you think about it all the time. And part of the reason I've done that is because for whatever reason I'm wired to care about low-income folks that don't have health insurance, and that's a real passion. That's what it's really about for me. It's not about the research, it's not about the providers. Sorry if you're out there, I don't really want to make you richer, but I really want to help people that need coverage. And so my message might be to people, if you know somebody out there who's in that category, who might need coverage, never had it, maybe even a single male who's healthy, get them signed up because they're eligible, and then they can go get a wellness test. But if your neighbor who's got some chronic conditions, definitely get them signed up. That's what this is designed for. And the federal government is paying 90% of the cost. So in fact, I think 100% of the cost. So this is the rare time that our Missouri dollars can go to Washington and come back. And that's good for the economy. I didn't even talk about that, but there's evidence that it's good for the economy. So, but the main thing is it's good for people that need it. So that's what I would say to people is, if you are privileged enough to have health insurance yourself, or to be able to navigate this, try to help some folks. And that's what some people are doing. So.
Good message to leave us with, Tim.
Yep.
Thank you so much. Pleasure as always. Cynthia and Sarah, wonderful to do this with you. To our audience, super smart questions, and I'm sorry that we didn't get the time to include them all, but our relationship with Tim is ongoing, and we hope you'll come back the next time we draft him for this calendar. With that, we're at time. We wish everybody a great rest of your day. Please come back to us for another program soon. And happy 2022, everybody. Please stay healthy and safe out there. We'll see you soon.
Thanks much.